name's Mr Srikandarajah. I'm a neurosurgical trainee at the Walton Centre in Liverpool, and I've recently completed a PhD in Cauda Equina Syndrome. I've identified with Cauda Equina Syndrome patients and healthcare professionals what the most important outcomes are in this disease area for which future research should be focused on.
What is Cauda Equina Syndrome?
So, Cauda Equina Syndrome is a clinical and radiological diagnosis. By that I mean it needs to have the clinical signs as well as the correct imaging for the diagnosis. So, in most cases. So, in terms of the clinical signs, if I describe the Cauda Equina first, so actually at the end of your spinal cord, at the lower end of your back, it suddenly starts developing roots, and they call it the horse's tail, hence Cauda Equina. And these roots supply sensation and power to your leg muscles, and also that area, the Cauda Equina, supplies control to your bladder, your bowel, and also your sexual function as well. So when there's a disc, which happens in most cases of Cauda Equina, pressing on that area, the Cauda Equina, invariably over time you can get dysfunction of these nerves. So therefore the signs would be leg weakness, loss of sensation, could lead to paralysis of the legs. Also you can get problems with your bladder function and your bowel function, so you can start getting urinary incontinence and bowel incontinence, so wetting and soiling yourself, and also sexual dysfunction, so loss of ejaculation or orgasm. So these are serious signs and symptoms which we need to be wary of.
What are the problems with Cauda Equina Syndrome diagnosis?
That's a good question. So I think there's two main issues. So the first is in terms of actually the clinical signs and picking up the clinical signs. So I think when it comes to the first port of call when the patient goes to see their GP or A&E, it's very hard to differentiate Cauda Equina Syndrome from the lower back pain and leg pain category, but there are some defining features which we call red flag signs that should alert a clinician or a professional to thinking this could be Cauda Equina, and that tends to be, if they start having issues with their bowel or bladder function, or if they start feeling numb in their genital region or the backside. These are issues which start making us think that area, the Cauda Equina, has been affected, rather than it just being a back pain or a leg pain issue, which is much more common in the setting of a GP or A&E. So that's the first sort of major thing. So we need to be picking up these red flag signs as professionals. And I think the second thing is the issue we have with getting an MRI scan for Cauda Equina patients. It's very difficult because when it's out of hours in the local setting, they don't tend to offer that in many institutions. And actually, because MRI scanning out of hours is only available in tertiary centres, patients find it very difficult to get a scan, and so do clinicians, and they need to be calling through to us, the neurosurgeons, to verify if it's important enough for us to bring over and do that imaging.
It is subjective as to what degree of compression requires urgent surgery. What is your opinion?
Yeah, I absolutely agree with that point. It is subjective. So the general thinking with us as surgeons is if there's a significant canal compromise, on the imaging, then this would constitute compressive Cauda Equina Syndrome. But as to what degree that is in terms of a percentage is always argued about in the studies. So it goes down to sort of the clinician's personal experience. And I think this is an area of research we need to look at, as in, is it that you need significant canal compromise before calling it Cauda Equina Syndrome? Or is it that there's, if there's smaller amount of canal compromise, there's maybe a local sort of reaction there, and that's still causing compromise of those nerves? We're not clear on that from the research yet.
What do you look for in a Cauda Equina referral?
Usually when I'm on call and I get a referral from another clinician because they're concerned about Cauda Equina Syndrome, there's some certain important questions that I would ask, and this would be, I'll go through them. Do you have low back pain? How long have you had it for? Has it got worse recently? Do you have leg pain associated with that? Is it on one side or is it on both sides? Okay, and where does the leg pain travel to? Okay, this is so that I can figure out which nerves might be affected. All right. The next question would be, are there any issues with the bladder or the bowel? Okay, and these issues can range from what patients who have Cauda Equina incomplete have. So that's not the full-blown version of Cauda Equina. So it could be that they have a bit of issues passing urine, feel that there's a bit of numbness down there but not complete, and in terms of opening their bowels, they just feel that there's been a change of habit recently and they feel a bit numb on their backside. To the full-blown version, where you would get a retention of urine, which means that your urine is being held up in your bladder and your bladder can't empty it, and it's painless usually, so you won't feel that as painful because the sensation nerves have gone. And also in terms of their sensation on their backside, we call it perianal sensation, perineal. So I would ask if they can feel it with a pinprick on both sides or one side in particular. And through studies it's shown that that's the most likely thing to go wrong if you are to have an MRI positive Cauda Equina, and it's the perineal sensation that starts going, and that's the most positive correlation. So those are the questions I would ask. I would also ask about a bladder scan. So we tend to ask what the post-void bladder residual is. So once you've passed urine, to do a bladder scan, and if you're holding a lot of urine even after voiding, it suggests that the bladder is not functioning as well as it should. So it gives a stronger indication that something's going wrong here and we probably need to get imaging. So those would be my main headline questions as opposed to the other questions.
What are your recommendations for rehabilitation?
So I think during my PhD I interviewed quite a few patients with Cauda Equina Syndrome, and the impression I got from them is that after having their surgery, the care tends to be quite disjointed, and it's not cohesive. So in essence, once the surgery is done, if you have a bladder issue, you tend to go and see a urologist. If you have a bowel issue, you tend to then go and see the general surgeons, and then if you have any sort of psychiatric issues, you get referred to a psychiatrist, but there's no one overseeing all of this. And what we have at the Walton Centre is we have a Cauda Equina Syndrome clinic, where one person acts sort of holistically looking at all of these features that need to be fed into your care, and I think that's what's needed, because the second thing I found with patients were they were really anxious about what they could do after the operation. So they were anxious, could they even go for a walk, pick up their child, if they could bend over, simple things that we take for granted, but they were worried that the Cauda Equina might come back if they start doing these things. And I think there's a real lack of information about what you can do afterwards, and obviously it's different depending on each patient. You have to look at the patient and what they've been through and what sort of operation or imaging they had before and what their outcome was, to give them that advice. And I think you need a bit more tailored advice, reassurance, and a more holistic service for Cauda Equina patients.
What are your thoughts on the current research available for Cauda Equina Syndrome?
So in terms of the research, we published a study a few years back looking at all the literature that's out there in Cauda Equina Syndrome, and we found that people are generally conducting low quality studies because they're doing it only at single institutions and they're not looking at the outcomes which matter to patients and healthcare professionals. And I think the landscape needs to change for Cauda Equina Syndrome in terms of research and services. I think one way of doing this is we need to develop a solid database for this syndrome which collects outcomes that matter to patients over a long period of time, so we can follow it up and figure out what the best way is to manage patients with Cauda Equina Syndrome.